I thought we will start with transmission dynamics of monkeypox and its impact on IPC. And it's an update of the current state. And I can take Q&A at the end. And if Dr. Brenda Ang is, by then she has joined, she can also coordinate the Q&A. So, let me see. All right. Monkeypox is a virus that was first detected as an outbreak among study monkeys in Denmark in 1959. And the first human infection was reported in 1970 in DRC. As you all know, it's a double-stranded DNA virus belonging to the Orthopoxvirus group. And it is related to variola, smallpox smallpox virus, vaccinia virus. They're all belonging to the same group, and they give cross-protection. So, diving straight into the transmission dynamics of monkeypox, we'll see the attack rate of monkeypox first over the history. And you can, this is the nice paper that was published in 2021, and the paper actually summarized the number of cases per clade of monkeypox, and they divided into Central African clade and West African clade. And you can see the number of cases have been increasing steadily over the years per outbreak. Like for the Central African clade, it has been like 38, 355. And then after that, the numbers seems to be reducing, but it also is also a function of confirmed cases versus suspected cases and how many have been tested. If we look at the West African clade, the numbers will also be lesser, so less than the Central African clade, but they've been increasing between 2009 to 2019, saw the highest number of under 95 cases. And this is a very nice older paper by Professor Heyman and group, and they actually analyzed the increasing trend in the number of cases of monkeypox and how the secondary attack rate have been, percentage of secondary attack rate has been increasing for monkeypox over the years as well. And from 7.5 to 9 to 23% as the secondary attack rate has been increasing. And they actually somewhat, rightly predicted that at the end of 20th century, okay, that happened a bit later, we are thus faced with the re-emergence of human monkeypox in an atypical epidemiological pattern. It's probably an understatement considering what we are seeing in 2022 during the current monkeypox outbreak. So the factors that are contributing to the surge in monkeypox and also the potentially differing presentation might be increase in population that is smallpox vaccine naive, and also somewhat reduction in the smallpox vaccination in the past. Most countries stopped smallpox vaccination around late 1970s and early 1980s. So those who were born after that may not have the nice smallpox vaccine scar. And also increase in global mobility actually makes it easier for not only monkeypox, but many other endemic diseases to be exported and imported. And also human encroachment into forested area actually facilitates the first infection of monkeypox. So risk factors for human-to-human transmission of monkeypox have been established from previous outbreaks. Sharing the same room or bed, same household, eating or drinking from the same dish, and were associated with transmission of monkeypox. However, interestingly, assisting with toileting or hygiene, laundering clothes were not associated with the monkeypox from the DRC data. So it'll be interesting to see the risk factors in the current outbreak. And I think the data are coming out and we'll probably likely see a lot more soon. Nosocomial transmission of monkeypox, the number of nosocomial transmission documented cases have been small. Exposures may not translate to infections in monkeypox because the general while the infectious dose of monkeypox is unknown, the epidemiology of the virus seems to suggest, at least so far, that higher infectious dose compared to variola might be required. This is just a suggestion, and in all honesty, I feel that we are learning a lot about the virus in this current outbreak, a lot more about the virus in this current outbreak. So this is something to watch out. Nosocomial transmissions have been reported, but not in high number. Like the references for the transmissions are given below. And we all know that in endemic countries, there may be transmissions, but they are not really, I mean, these subjects are not really a popular subject. So unless there's a large studies, they may not really get published. So it's good to get experience from our friends on the grounds rather than publication. But from published report, there were like this study, this publication that showed that, you know, a hospital nurse and doctor got infected. And we all are aware of the UK case in 2018, I think, where a nurse got infected. And I think the epi investigation suggested, you know, she ended the patient linens, and that might be the source. So nosocomial transmission risk as of now doesn't seem to be very high. And but also could be because, you know, most of the countries are aware of the virus and are more prepared. So past experience of imported case cluster management have generally been good, but the current outbreak may not be the same, and we know it's not the same. And most countries are experiencing within country transmission, including Singapore, where, you know, there was a case of monkeypox reported locally, but the investigations are still ongoing for that. But most of our cases are imported. This is our case of imported monkeypox in Singapore in 2019. You know, we had we had about 22 community contacts, 19 the index patient went to a workshop, and 19 workshop attendees and 4 hotel staff were quarantined. 14 of them agreed for ACAM 2000 post-exposure prophylaxis. 6 declined, 2 had contraindications. None of the contacts developed the disease. And for hospital contacts, it was we were luckier because by the time the patient was being transported to our hospital, we already know the patient is a suspected case, so there was no unprotected exposure at that time. But for the current outbreak, previously established risk factors and transmission risks will need to be re-evaluated, and all of these are ongoing, and we need to see. For the transmission risk, we know we do have some ideas that it could be related to you know, certain population group and certain activities. Currently is MSM who have sex with men, maybe slightly a higher risk, but we're already seeing child infection among children here and there. So the risk profile will change. We need to be aware of that and keep a close eye on this data as they come out. The next part of transmission dynamics that I'm going to talk about is the modes of transmission. You know, in all honesty, there's limited data available for a virus that has been circulating for decades. Since we received our first case a couple of weeks ago, we have already sampled the environment, air, water, and surfaces, but unfortunately, the data is not ready for sharing at this stage. So we'll be reviewing data that is available so far in this presentation. So what are the possible modes of transmission? And this is a summary from available data. And then I will show some papers. Zoonosis is uncontested. So there's a strong epi support and historical success of controlling the virus or linking the virus to zoonotic origin. It's a driver of endemicity, and that's why most of us are concerned about reverse zoonosis during the current outbreak. Direct physical contacts or touch-based transmission, it's also not contested, and it is has a very strong epi support, especially during the current outbreak. There's historical success by preventive measures that prevent direct contact seem to work. It's logical because the way how the virus presents, the disease presents, and it's likely the driver of the current outbreak. Environment or another touch-based transmission can be physical, direct physical contact or indirect via environment. There's a moderate epi support for it. In the last 1 week, there are 2 papers that has done environmental surveillance and showing viable virus in the environment have been published. I'll show these papers quickly later. Environment transmission and the DNA viruses are generally stable. Although we do know there is a string of activities that need to happen when for environmental transmission to occur. And in an environment where the bioburden is high and human activity is high, especially if it's unprotected, then the transmission link may be established better. You know, the environment needs to be contaminated and someone needs to touch it unprotected or protected and then touch their eyes with gloves or self-contaminate themselves while adopting the PPE if you are talking about healthcare workers, or in the community where that might not be the case and they can just self-contaminate. But it has to happen, that string, and the virus must have the infectious potential. There is historic success as well because environmental cleaning is part and parcel of infection prevention and control together with personal protective equipment. So there is established historical success that this is actually a potential source. And the surface contamination by infectious fluids, scabs, respiratory droplets, or indirect droplets are possible. So I would like to use the phrase spray of infectious particles instead of droplet. We need to differentiate between saliva contamination of the environment or droplet or spray. So there's possible epi-support, logical because there's a respiratory phase of the virus. Not everyone goes through the respiratory phase. Now, 4 monkeypox cases, only two potentially had respiratory symptoms, which was short-lasting. There's no laboratory support for droplet. There's no one has done that. There is a particle size or spray base more than 100 micron that has been shown to carry the virus or link the transmission back to infection, contamination back to infection. That hasn't happened yet. It's historically accepted. So droplet is it's a historically accepted mode, and that's why generally from long time ago a surgical mask or medical mask has been recommended for monkeypox. Near distance aerosol via inhalation is a possible route of there is a possible epi support, but not human epi, more like animal epi. There has been documented animal to animal transmission of and likely source could be aerosol, and there's also animal to human transmission by likely source being aerosol. It's also logical when there is a respiratory phase that could cause a droplet or spray-based infectious particle. It's not unlikely that it will also cause aerosols that can actually, travel just slightly short distance. When we say aerosol, it doesn't really have to go very far. Aerosol actually concentrate highest within the patient zone. So if there's a fine particles and you are within the patient zone unprotected, there is a likelihood of getting infected. There is laboratory evidence for near distance aerosol. I'll show this later, but this is historically unsupported. It's not popular and it's contentious, as we all know. Long distance aerosol, also inhalation, there is no epi support for this. No laboratory support. Lab support is somewhat similar to the near distance, I'll show later. Plausible near distance aerosol is proven, especially in enclosed environment. Is especially enclosed environment. But by this, I'm referring to the fact that if near distance aerosol is proven and the ventilation is poor, then the aerosol may linger longer and travel longer, as opposed to poor ventilation environment. Obviously, this is historically unsupported as well. And then we have semen and cervical vaginal fluid-based transmission. In this current outbreak, this discussion has taken prominence. There have been papers that have been published that showed presence of viral particle in semen, but to prove that this actually happens might be quite tough. We will get more data. Like Ebola, initially we didn't know, but lately, about a few years back, only we knew that the transmission, it can remain and then the transmission could occur. So we should not discard any mode of transmission. We should, until it has been, more studies have been done around monkeypox virus. So when we have so many modes of transmission, I thought I will actually categorize them by acceptance scale and evidence scale. So for zoonosis, the acceptance scale is high, and I believe the evidence scale is also high, because There's been lots of zoonotic reports, and the epidemiology just supports it, and not contested by, actually no one contests this, although we don't know the definitive animal host for the virus. There's some suggestions. And then there's direct physical touch. This also, the acceptance scale is very high, and the evidence scale based on the epi support seems very strong. So it seems very good. So I've given it 3 kernels for the evidence scale. For the environment touch-based transmission, the acceptance scale, as we all know and we all agree, I don't think anyone in this group will contest that touch-based transmission for environment may not happen. It can happen. If any one of the rest can happen, that might be the most obvious. But the evidence for it, with the previously I put one nut for it, but now I have increased it to 2. After the 2 environmental surveillance paper that just recently came out, it has become 2 kernels. And then droplet and spray of droplet-based transmission. Actually, most guidelines actually talk about this. They do say you have to have droplet-based precaution. So it is accepted by most existing authorities, but evidence scale, I'm not sure I've seen enough evidence to support droplet. Similar to the near distance aerosol, the evidence is almost non-existent at this moment. I will show the laboratory data later. I would like to wait for near distance aerosol sampling, like we have done, until such sampling has been published in peer-reviewed article. We may not be able to say that the evidence is suggestive or even good. The acceptance scale is less than droplet for sure, because it hasn't been accepted so far that near distance aerosol is possible. There are many reasons for it. The epi doesn't support, etc. So this is where this is how my conclusion revolves around near distance aerosol. Long distance aerosol, yes, the acceptance scale is still processing, meaning mostly not accepted, and the evidence is pending. I almost never say there's no evidence. I always say pending evidence, unless it's very, very obvious and the evidence has been going on for some years. It's very difficult to say that there is no evidence. I always say pending. Same goes for semen and cervical vaginal fluid. With the semen discovery, I think the kernels should increase to 2, but the number of beavers will remain the same, I think, for now, because the acceptance scale is not there yet. It's just a lot of hype around it. So we like to see more of it. So on the data about surface contamination and stability, environmental stability or duration of survival is important for IPC, because as we had seen recently or in our previous case, the quarantine duration for items or surfaces that cannot be disinfected easily. For example, passport of a traveler or money or currency notes. Contact tracing for environmental exposure, that also depends on the duration of survival and stability. There is no data on duration of survival for monkeypox virus on surfaces, and 2 studies from 2022 outbreaks have shown extensive environmental contamination with recovery of viable virus. So these are the kind of first starting studies that we need for a new virus or an old virus that hasn't been investigated as much. So, but no study on environmental stability of monkeypox yet, like what we had for variola and also vaccinia in the past. So this is the first study for the environmental contamination monkeypox virus. This was based on a 2019 data, but just now in medRxiv. So we can see that it's from UK and home swabbing data, and you can see the virus isolation. There's viable virus isolated from mattress, towel, iPad, handle to patient's residence, duvet, sofa, etc. And there's extensive contamination. The detection of viable virus, the CT value actually goes up to 31.6. 31.6 from vacuum shows the virus can still be viable. So this is very interesting data, because 31.6 is generally not a high viral load, it's low viral load, but it's still culturable. The next is the Eurosurveillance paper that just came out. The references for both these papers are down here if you're interested in reading. This is a room surveillance of a patient room surveillance in the hospital, whereas the first one was community. As you can see, there were extensive contamination with the toilet area, the toilet seat, and the sink not having extensive contaminations. This is somewhat similar to what we found, and they also found viable viruses in these areas. So what do we or I can conclude from here is that the touch-based transmission of environment has more data now, and it is of concern, and we need to prevent that from happening, especially in hospital setting, like with our environmental hygiene measures, and also PPE. So this is the conclusion that we can make. But to prove that the transmission actually happened from the environmental contamination, it may never happen because we always keep cleaning unless we can do it in community setting. Patient A goes into a hotel room, stays, and then leaves, and eventually diagnosed with monkeypox. Patient B goes into the same room and stays, but the room was not properly cleaned, and eventually diagnosed with monkeypox. Some people consider this as possible evidence if they are genomically linked. But if you swap the environment after patient A, and the data say the results not available, and then patient B was infected, and then you link all of them together, then that becomes stronger. If you all recall, this is how they, I can't remember the group's name, but they actually, the IJID paper where they showed that COVID virus air sampling result was a linked first patient to a newly diagnosed patient. So this is the environmental contamination. In terms of stability of since there is no data on monkeypox virus stability, I thought we could actually refer to previous, its relatives to see how those survived in the environment. And it's a bit scary because they survived quite well in the environment. Like variola virus, the smallpox virus, CAB at 35 degrees was stable up to 3 weeks. It was culturable up to 3 weeks. At 26 degrees, 8 weeks, and 4 degrees up to 16 weeks. And pustule mounted on slides were recovered by 9 months later. This is a study from India. And then for vaccinia virus, it's about same. And if you can see, this is interesting. Gauze, bandage, bread, salad, and sausage. It lasts up to 14 days. So other orthopox viruses survive quite long in the environment. And if we are thinking about quarantining the patient's personal items or any other articles, at the moment, the answer is we don't have data for monkeypox. But if we want to quarantine for vaccinia virus, yes, we have some data. It looks like it can go up to 2 weeks, generally speaking. Right. Air contamination and stability of the virus. There is a laboratory study that estimated survival of monkeypox virus in the air for up to 90 days. The study was stopped at 90 days, not like the virus did not survive after 90 days. So this is the only study before the current outbreak that was ever done for environment, was done in a laboratory setting. So this showed that the virus in a laboratory setting can survive in the air. It doesn't need a human host or only in the environment. If it's in the air, it can survive. But the possible of, but the thing is, just because humans were exposed to the virus, it doesn't automatically mean that you'll get infected. That's why previously we discussed the infectious dose of monkeypox, which is also not known. The virus is mutating, things may change, but currently it doesn't look like it has the epidemiological support of large-scale outbreak. But can it cause 1 or 2 infections by these modes of transmission? It is definitely possible, but as I said just now, for air transmission, I would want to wait for sampling of the airborne virus. And then generally speaking, after COVID, personally, I mean, as in this is just my personal opinion, that I may not wait for viable virus. I may just go by detection of viral particles in the air to provide protection for our hospital staff. I'm not talking about community. This is very debatable. I'm sure 70 to 80% of the participants in this webinar may not agree. Another 5 to 10% may not only they may not agree, they may have a contentious counter arguments, but that's what I feel. Possible animal infections explained by aerosol routes of transmissions have been reported. Now, the interesting thing about this monkeypox virus is, where could a respiratory airborne particle come from? It's not only the exhale virus. I feel the resuspended viral particle from the dust, because the dust samples are quite viable in this virus, as we saw from the studies that we just saw, like the Med-Archive, the community study. The dust particles have contained viable viruses, and they can resuspend. We also know varicella zoster virus can be excreted via aerosolization from skin lesions directly. Could that happen with monkeypox as well? These are the things that actually needs in further investigation. But obviously, I'm saying this again and again. Finding of virus, viable or not, in the environment, surface, air, water, or dust, doesn't automatically mean that the virus will cause infection via that route, because there's other part of the equation. The other part of the equation is the infectious dose of the virus. Can we reach that with the environmental contamination? Number two is the infection potential of the virus. We know that the Wuhan variant of the original ancestral variant of SARS-CoV-2 was different from the subsequent variants, Delta and now Omicron. Will monkeypox, once it finds a human niche in a wider population, will it change? We don't know. But so it's good to gather these data now and prepare in case it happens. So what are the data that's required still? Proof of presence of viral particle on surfaces and extent of contamination. Proof of viability would be a bonus, and there are 2 studies out so far that have shown this. Proof of presence of viral particle in the air and proof of viability would be a bonus. So far, there has not been any published studies. Duration of viability of viral particles, including scabs on surfaces and in the air, will be good for in real life setting, not in laboratory setting. And incorporation of genomics to prove chain of transmission, human surface, human, or human air, human, will be good, but this is very difficult to do. And also extent of asymptomatic carriage. So in this older study, there were 20% is in a WHO Red Book. There's a chapter on monkeypox. In that, there is a report of up to 20% zero evidence for monkeypox, present exposure to monkeypox without symptoms. And recently, there's a paper that showed that, I think it's from the UK. Sorry, I didn't put that paper in, where that 3 out of 200 odd patients who attended the sexual health clinic were positive for the virus by rectal swab without symptoms. So there is evidence for asymptomatic carriage, but we don't know whether the asymptomatic carriage may cause onward transmission or not. That we don't know. These were the questions we actually had for COVID, and we eventually found the answer because of the nature of the outbreak and the scale of the outbreak. And epigenomics analysis to confirm if sexual transmission is possible is also pending. So these are the summary of the modes of transmission. Now, I'll jump. Precautionary principle has become front and center during COVID. And what is, so when we talk about parachute, right, that's the analogy, isn't it? Do you need a randomized controlled trial for parachute? And this slide's just for fun. There is a paper in BMJ, which actually did a systematic review of a randomized controlled trial evidence for parachute to prevent death and major trauma related to gravitational challenge. And their conclusion was, we were unable to identify any randomized controlled trial for parachute intervention to prevent such a trauma. And then there's this very interesting, another study, which was done to see, it's a randomized controlled trial used to prevent death and major trauma when jumping from an aircraft. Randomized controlled trial, mind you. So what they did was, all participants were asked whether they would be willing to be randomized to jump from the aircraft at its current altitude and velocity. Potential study participants completed an anonymous survey using a survey app on the screening investigator's phone or tablet. Responses were transmitted to an online database upon landing for later analysis. So it was a very well implemented study. So this is how they jump from the plane. And when they talk about the plane at the current altitude and velocity, this is what they're talking about, with a fan and jumping from the plane in that height. So the study also has several limitations. First and most importantly, our findings might not be generalizable to the use of parachute in aircraft traveling at higher altitude and velocity. Consideration could be, because no one wanted to jump from there, consideration could be made to conduct additional randomized trials in these higher settings. I mean, these are just fun, right? It just shows that sometimes for some things, you may not be able to wait for the data before implementing a precautionary measure. But data will be coming. So we should be able to communicate the risk to the hospital and our staff, and also prepare them to be ready to if the risk changes or the evidence changes. We all know PPE is not so just as a PPE is giving PPE includes training, education, supply issue. Will we have continuous supply? There are many things. But if we don't prepare for COVID happened, and eventually it is obvious that N95 was needed. And then if we are never prepared for that, now monkeypox may not be a big pandemic, may actually become a low-level transmission endemic virus maybe soon. But if you don't prepare for it again, then what about the next pandemic, right? So that excuse about, supply might be an issue, may be difficult to sustain on long term. So this is the RCT for parachutes. So what is precautionary principle? I'm sorry I didn't put the reference. I can send the paper around if people are interested. So precautionary principle is best known for its use in the field of environment protection. In the field of treatment or other interventions, PP places hurdles in place to reduce probability of harm for treatment, where there are assumed to be greater risks involved in moving away from status quo, that is moving to a new treatment, than staying there, which is the existing treatment. So it is actually designed to put a break in it. But the authors of the paper argue that in the field of public health, that might not be the case. In public health, is mostly concerned with preventing future harms. So it is not about staying current because of the harm of an intervention. It's about going to a new intervention to prevent the future harm. So it's very complex, but we know that precautionary principle is something many of us have used, many people use them at us as well during the COVID pandemic. So with all of this in mind, what is the PPE approach that we use in NCID and TTSH? So human-to-human transmission potential very likely to be lower than COVID-19, except for household transmission setting or close bodily contact. For hospital staff, it's likely to be low. However, our PPE approach may need to be conservative and follow precautionary principle until more data are available, and we think data will come. And our PPE includes N95. It will be removed and discarded after every patient contact, because we also want to wait for PPE contamination studies to see how we want to. Do we want to use extended use like for COVID, or do we want to, what will be the strategy? So we also give shoe covers for housekeeping staff and staff involved in housekeeping activities, because we are worried about resuspended dust particles. But generally, this is the PPE: N95 mask for healthcare workers, AMI level 4 waterproof gown, gloves, and eye protection. Except for porter transporting clinical samples, only surgical masks, because this is our national policy currently, indoor surgical masks for COVID. So as a conclusion, historically, sustained person-to-person transmission have been uncommon for monkeypox virus, as it requires significant close contacts and usually household contact. It seems to be the same for the current outbreak. Apologies. We all are recovering for one thing or another. The ongoing 2022 outbreak needs further investigation, human behavior-related factors, virus-related factors. There are new mutations. So what is the impact of the mutations? Population naivety from smallpox vaccine or lack of smallpox vaccine exposure. Until more evidence emerge, the routes of transmission in order for hospital priority hospital IPC might be, in the setting of good PPE, might be contaminated clothing and linen, because there was one transmission reported previously in the UK, and high load of scabs, blister fluids, etc., and proven environmental sampling study that we saw before. Contaminated environment, direct contact with contaminated environment, and resuspended aerosol dust particles with scabs from environmental sampling. Direct patient contact is very well proven, so we need a PPE to cover that gown and glove. And also respiratory aerosols seem to have a theoretical risk from laboratory studies, and also because there's a respiratory phase to the virus and animal studies. So as part of precautionary principle, protection against aerosol might be required at this stage. At least that's what we are doing in NCID, in Tan Tock Seng. But we are always ready to change our PPE based on as the evidence move forward. So with that, I end the current IPC my presentation, and if you have any questions, I can answer. Otherwise, this is the next session on 16 August. I'll send around the details later.